But today we're welcoming Professor Nick Latimer. Nick teaches on the Health Economics and Decision Modelling programme that I mentioned earlier on, and also supervises PhD students in SHAR. During his time at SHAR, when did you join SHAR, Nick? I'm thinking maybe 2010, 2012?
2008, I think.
Oh, okay. Not as long as me, but and I'm not as long as Andy. But no, Nick has been with us for quite a long time and has completed an NIHR doctoral and postdoctoral fellowship in that time. And he's currently doing a senior research fellowship funded by Yorkshire Cancer Research, and it's the topic of that fellowship that today's presentation is focused on. So is it okay if I hand over to you now, Nick? I'll just stop sharing my slides.
Yeah, okay. So you should be able to see my slide now. Okay, so hello everyone. Thanks very much, Claire, for the introduction, and to Andy for inviting me to talk, and for organising this mini masterclass series. And thanks very much to everybody who's logged on. So as Claire said, I'm going to be talking about estimating the comparative effectiveness of cancer treatments using UK registry data, and whether results of such analyses can be considered to be fact, i.e. they're a reliable reflection of treatment effectiveness, or whether they might not be fact, they might be more likely to be fiction, in other words, not very reliable estimates. I actually added the fact and fiction part to the title of this talk to make it sound more exciting, but it's had the unintended consequence of forcing me to try quite hard to make this talk a bit more interactive. So I've got some animation and also some polls. Anyone who saw my tweets about this talk will know that I quite wanted to also have sound effects, but unfortunately I haven't managed that. So when you see the fact and fiction animation pop up, you'll have to imagine in your head things like explosions and thunderstorms, unless Andy Tattersall decides to unmute himself and make those sounds himself. I'll leave that up to him. But seriously though, I am very well aware that Zoom fatigue or Blackboard fatigue or Teams fatigue, whatever you use, is a real thing. So please do take part in the polls, and hopefully this talk about causal inference, directed acyclic graphs, front door and back door paths will be enough to keep you awake. So before I begin, I need to acknowledge my funders, Yorkshire Cancer Research, and also the people who are collaborating with me on this work, who are all listed here. Of particular importance are the two PhD students here that I'm supervising, so Amy Chang and Salima Rex, who are going to be conducting some of the research that I'm going to be talking about. Amy is funded by the Wellcome Trust, and Salima is jointly funded by Yorkshire Cancer Research and BRESMed. So thanks very much to all those people and all those funders. I also just wanted to spend a minute explaining why I'm doing this work. So I'm a health economist and have been working on economic evaluation of healthcare interventions for almost 20 years, which for me is quite hard to believe. I don't think I'm that old. So, but most of that time has been spent here in Sheffield, and most of my research has focused on methodological issues to do with survival analysis, so basically trying to work out the best methods for estimating the survival benefits associated with new treatments. Now, in recent years in HTA, health technology assessment, there's been a big growth in interest in using real world data or big data, partly due to some new treatments not being compared in randomized controlled trials, and partly due to the general growth in interest in data science and how we can use the reams of data that we collect to do helpful things. But I think a big concern with this is that analyses of observational data can be misleading. If the analyses are done badly, or if the data aren't good quality, we could be misled by the results. And if we use those results to inform healthcare decision making, we could make bad decisions, which is bad for everybody. I'll be saying more about why observational data analyses can be misleading later on in this talk. So I knew a bit about causal inference methods from some of the previous work that I've done on treatment switching adjustment methods, but decided I'd like to do some research in the area of observational data, which led to my current fellowship funded by Yorkshire Cancer Research, which has got the title Survival Analysis and Statistical Modelling to Facilitate the Clinical and Economic Evaluation of Cancer Treatments, Making the Most of Data. So all of this led to this question: can we reliably estimate the comparative effectiveness of cancer treatments given in the NHS using English registry data? And if we do these analyses, will the results we get be fact, denoted by this kind of firework explosion, make the sound effects in your head, or will they be fiction, so denoted in this presentation by a gloomy rain cloud? I don't really know what noise a gloomy rain cloud makes, but you could do something that you think is appropriate. So now I will get onto that question about comparative effectiveness using English Cancer Registry data, but first I want to briefly talk about why we're trying to use big data in this way, because this in itself is quite controversial. So obviously new treatments are usually compared in randomized controlled trials, and randomization brings with it many benefits. In particular, it means patient characteristics that may influence outcomes are randomly distributed between the randomized groups. So if we give one treatment to one randomized group and another treatment to the other group, we can attribute any differences in outcomes between the two groups to the treatments they received. Now I just want to clarify here that the fact that I'm going to be talking about using observational data to estimate comparative effectiveness does not mean that I think we don't need RCTs. I know that kind of area in debate is a big one, but definitely in my opinion RCTs remain crucial and offer the best evidence for working out how effective new treatments are. But RCTs also have limitations. They often have strict eligibility criteria, so new treatments are often tested in quite narrowly defined populations, so sometimes their generalizability might be questioned. Trials often also have quite short follow-up periods. They don't carry on for years and years, and so long-term treatment effects might be uncertain. And trials usually also have a limited number of comparator groups, whereas sometimes there are actually several other treatments that we'd like to compare a new treatment against. And sometimes RCTs just aren't feasible for a variety of reasons. If we think about technology appraisals done by NICE in the UK, there's definitely a growing number of those appraisals where evidence is for new drugs from single-arm studies. And that's particularly the case, I think, in cancer. So for all of those reasons, and given that we collect a lot of cancer registry data anyway, it's important, I think, to investigate whether we can reliably use the data that we have to estimate the comparative effectiveness of cancer treatments given in clinical practice. So, what data do we have in the UK that could help us with this? So in the UK, we collect large amounts of data on cancer patients, and this is all held, mostly held anyway, by the National Cancer Registration and Analysis Service, NCRAS. So the data that they have includes information on patient characteristics, tumour characteristics, hospital episodes, treatments received, outcomes, and I'll be saying a little bit more about those data sets later on. But first, before I get into the details of that, in general, what are the issues with analysing observational data? Because we need to address those issues in particular before we start thinking about the data that we have for this particular analysis. So in general, can we reliably estimate comparative effectiveness from observational data? So let's think about that for a bit. So the main problem associated with estimating comparative effectiveness using observational data is confounding. When I talked about RCTs a minute ago, I said that a key benefit was that it means that patient characteristics that may influence outcomes are randomly distributed between randomized groups. But in observational data, we don't have randomization. So treatment received is likely to be related to prognostic characteristics. That is confounding, and it's a problem for analyses of observational data. So have a look at this graph, which is called a directed acyclic graph, or a DAG. Now, I think these are pretty useful for looking at how we should do observational analyses of observational data. So imagine we want to estimate the effect of treatment A on outcome Y, which might be something like survival. So treatment received might be related to prognostic characteristics denoted in this graph by V, which could include things like performance status or tumor size or something else. So in the language of causal inference, this means that there's an open backdoor path between treatment A and outcome Y because the prognostic characteristics V influence both A and Y. So that's V is our confounding variables. So if we want to estimate the effect of A on Y, we need to block that backdoor path by including the variables V in our statistical model. This is fine, we can do that as long as all the important V variables are included in our data set. As an aside here, thinking ahead to what we're going to be trying to do with cancer registry data, NCRAS data does include information on things like ECOG performance status, time since diagnosis, Charlson comorbidity scores, and several other things. But we don't yet know the quality of that data or whether other important variables could be missing, but something to bear in mind. So in a situation like this, we can estimate the effect of A on Y provided we have data on the relevant prognostic variables and control for them in our analysis. But things usually get more complicated than that in analyses of observational data sets, and that's due to something called time-dependent confounding. So again, imagine we want to estimate the effect of treatment A on outcome Y, but this time treatment can change over time. So you've got treatment at time 0, A0, treatment at time 1, A1. So here the effect of A on Y has two causal paths. So there's a direct effect of A on Y in this graph shown with the blue arrows. And there's also an indirect effect where A affects future values of the prognostic variables V, which in turn affects Y. So for example, treatment might reduce the size of a tumour, and tumour size might be one of the variables in V. And that in turn improves the probability of survival. So that's kind of an indirect treatment effect associated with A. Usually we want to estimate this combined total effect of A on Y. That indirect part of the effect is relevant because it's still caused by A. So imagine we want to estimate this total effect of A on Y. What problems might we have? So again, initial treatment received might be related to the prognostic V variables, so that red arrow. But initial treatment also influences future values of the prognostic variables. And then those values of the prognostic variables influence the subsequent treatment decision and also affect survival. So in this case, we actually have a big problem. We want to block the backdoor paths between the V's and A's to avoid the confounding, but if we put the V's into our statistical model, we end up also blocking a front door causal path between A0, V1 and why. And that's that indirect effect that I talked about before. And we don't want to block that path because it is part of the effect of A. So in this case, the variables V are called time-dependent confounders. And what this means is if there are time-dependent confounders in our analysis and we use standard statistical models, our results will be fiction. And it's a real legitimate concern that potentially quite a lot of published analyses of observational data that try to estimate effects are in fact biased because of this problem. So this is a really big problem when we're thinking about analysing observational data. So instead of those simple standard statistical analyses, what we need to do here instead is use causal inference methods, or G methods, which allow us to estimate this effect of A on Y. Now, I'm not going to describe how these G methods work today because that would take quite some time. And in fact, last week I was teaching a course on this with colleagues at UMIT in Austria, which took up the whole week. And in fact, learning about these methods took up pretty much the whole of my PhD years ago. So it's not easy to explain in a few minutes. But if you are interested, then please sign up to that course at UMIT for next year. But essentially what these G methods do is remove the arrows from the V variables to A using pretty advanced statistical methods. And that leaves us with the causal effect pathways associated with treatment, which allows us to estimate the treatment effect without bias. Again, provided we have good enough data on the prognostic variables in V. So the conclusion here is that in circumstances like this, which will be very common in observational data, we can estimate the effect of A on Y, but only if we have data available on all the relevant variables and we use the right analytical methods. So in theory, we can do these analyses if the data are sufficient. But whether observational data sources are good enough to allow these kinds of analyses is a different question. So it's worth looking at whether people have actually managed to do these kinds of analyses successfully using observational data. So I think the first time this was really demonstrated in a clear way was all the way back in the year 2000 when Miguel Hernan and colleagues published work on assessing the effectiveness of sidovudine antiretroviral treatment for HIV positive men. So several small RCTs addressing this question existed already, but data was also available from a study, an observational study called the Multicenter AIDS Cohort Study, MAX. And according to the RCTs, sidovudine led to survival benefits with a rate ratio of around 0.5 to 0.7. But it made sense to try to estimate the effect using the bigger data set available from MAX to see what the effect looked like in clinical practice. So that's what the authors tried to do. So this is a DAG we can use to think about the analysis here, and we're interested in the effect of sidovudine, so ZID, on survival. Now, I admit that I've simplified the case for the purpose of this talk, and the actual analyses that were undertaken were a little bit more complicated. But I wanted to talk about the key principles to show these methods in action. Obviously, to get the full details, then please do read the full paper. The issue here was that sidovudine was a treatment that could be start and stopped. It was time dependent. So as we saw before in the hypothetical example I gave, there are several causal paths here. There's a direct effect of sidovudine on survival, and there's also an indirect effect through CD4 count. So sidovudine increases the CD4 count, which in turn improves survival. And combined, this direct and indirect effect equals the total effect of treatment on survival that we want to try to estimate, or what the authors wanted to try to estimate. But there are also backdoor paths here. So a low CD4 count is a trigger to initiate treatment. So people with low CD4 counts, therefore, tend to get treated with sidovudine. And CD4 count is also caused by the severity of the disease, so higher severity, lower CD4 count, and itself is a cause of death. So it's a tricky analysis. And we want to estimate, the authors wanted to estimate the total effect of sidovudine on survival. So what do we need to do? So this is where I've got a few polling questions to see what you think. Luckily, I've got Luke behind the scenes to help do these polls. So Luke, I'll tell you when to put them up.
Okay.
So first of all, how about an unadjusted analysis? What if we just do a simple statistical analysis looking at the effect of sidovudine on survival without adjusting for anything? So Luke, here's a poll. If you can put the first one up now. So will this unadjusted analysis give us a result that is fact or fiction? So the poll's up. So I'll give you a few seconds to put your answer.
Nick, currently people can't see any of the responses, but we have the option to show them back to everybody if and when you're ready.
Yeah. I'm happy for people to see the responses when they're ready.
I just don't want to show them from the beginning, perhaps to influence people.
Yeah. We'll give it a few more seconds. I won't spend too long on it. Okay, so 10 more seconds and then we'll show the results. Okay then, Luke, show us what people have said. Okay, so almost everybody who voted voted fiction, which is good. It is fiction because there are open backdoor paths. People who get sidovudine have worse disease. So if we compare those who didn't get treatment and those who did and don't adjust for CD4, it looks like sidovudine treatment is bad. And this was shown by Hernan et al. As the rate ratio for that analysis was 3.6, suggesting that the treatment was associated with much worse outcomes than no treatment. But obviously that's not right. So if we take those results down, how about if we do a standard statistical analysis that adjusts for CD4? So not using G methods or anything like that, just a standard statistical analysis looking at the effect of sidovudine on survival that adjusts for CD4 count. So Luke, if you can put up the same poll again for this one, would this analysis give us a result that is fact or fiction? So I'll give people 30 seconds or so. Five more seconds. Okay, Luke. Okay, so a little bit more balance, but still most people say this is fiction. 83 say fiction, 21 say fact. So again, this is fiction because we close a front door path between dose at time 0 or treatment at time 0, future CD4 count at time 1 and survival. We block off that indirect effect of sidovudine treatment. In fact, we also open a new non-causal path between treatment at time 0, CD4 at time 1, severity and survival here. That's a bit more complicated, but it's because in this case, that CD4 count at time 1 variable is what's called a collider variable. And strange things happen if we condition on colliders. So I'm not going to talk more about that here. Again, if you're interested, sign up to our course at UMIT. But the conclusion is that a standard statistical analysis that adjusts for CD4 here gives us a fictional result. And again, the simple analysis suggests that the sidovudine treatment results in more deaths than no treatment with a rate ratio of 2.3. And again, this isn't right. So what if we use a causal inference or G method? In this case, the authors used inverse probability weighting in a marginal structural model to try to remove those arrows between CD4 to zidovudine treatment. So Luke, let's have the last poll. If we did this G method analysis, would this give us a result that is fact or fiction? In your heads, you might also like to try to guess what you think the rate ratio would be here. So I'll give you 30 seconds. Five seconds. Okay, Luke. Okay, so 78 are saying fact, 8 are saying fiction. This was, I guess, a little bit loaded because I've already told you about the wonder of G method. So if you apply it, then we should get a result. I mean, you certainly could argue that it might not give us a brilliant result if we don't all have all of the relevant variables, but assuming we do. So in this case, it did appear to be fact. So the analysis gave a result very similar to that seen in the RCTs. So without doing that G method analysis, there would have been concern here because the simple analyses of the observational max data seemed to suggest that zidovudine treatment actually caused death in clinical practice, which didn't fit with the results from RCTs. But using the correct type of analysis, it was possible to remove those backdoor paths, control for the time-dependent confounding, and estimate the true treatment effect on survival. So again, we can do these types of analyses, provided we use the right methods and we have the right kind of data available. For example, if we didn't have good measures of CD4 count over time, we wouldn't have been able to do this analysis properly. Okay. So one of the things that you'll have noticed from that example is that the results of the observational data analysis were compared to the results of existing RCTs. Eventually, we want to go beyond that because we want to use the observational data to try to answer questions that haven't been addressed by RCTs. For instance, where drugs have been developed in single-arm studies or where RCTs include much narrower populations than those treated in practice. But although definitely not foolproof, trying to replicate existing RCTs using observational data sources does provide a way for us to evaluate the analyses to see if they seem to have come up with reliable results. And doing that seems like a sensible first step to tell us whether the data sets we have seem to contain enough information to enable us to come up with reliable results. And then if they do, then we can go on to further analyses beyond the questions answered by the existing RCTs. So other researchers have taken a similar approach to this, with analyses using different observational data sets in a variety of disease areas. So I thought it'd be useful just to summarize some of those pieces of work here. I won't spend long on these. So one important application of this type of approach is the RCT duplicate study, which is being funded by the FDA in the US and being conducted at Harvard. So this project it involves replicating 30 treated RCTs using US claims data, applying the eligibility criteria from the RCTs to the observational data to try to match up, and using appropriate analytical methods, G methods, to control for confounding in an appropriate way, and then comparing the results to those from the RCTs to see if the analyses seem to be reliable. So far, the results are published for the first 10 of those trial emulation analyses, and those were all of anti-diabetic and anti-platelet medications. And in those first 10 analyses, the authors have found that the emulations using the real-world data resulted in treatment effect estimates that were within the 95% confidence interval of the corresponding RCT results in 8 of the 10 analyses. So these seem like reasonable results, but there is uncertainty. It's not clear that these kinds of analyses were always successful, and the authors remark in the paper that it wasn't always possible to fully match the RCT and registry populations and treatment strategies, possibly due to the available data from the claims data not being quite good enough. Other work in the US has been published by Petito et al., in fact with Miguel Hernan as a co-author, whose name you might recognise from the antiretroviral study I talked about earlier. And the authors attempted to replicate existing RCTs in colorectal and pancreatic cancer using SEER and Medicare linked data, where SEER is the Surveillance Epidemiology and End Results Database, which is like a large US registry. So the authors found here that when they used standard or naive statistical analyses, not the G methods, their results didn't match those from RCTs. But when they used the more appropriate G methods, they were able to produce results that matched those from RCTs. Similar work is also happening in Canada through a project called Can Revalue. I haven't got loads of time today, so I won't say more about that here. Maybe more relevant is similar work that's also been done in Scotland. This Scottish study I think is of particular interest for me because the authors attempted to determine whether it was feasible to estimate the effectiveness of chemotherapy for breast cancer using Scottish cancer registry data linked to hospital data, which are quite similar to the data sources I'm going to be using and Amy and Salima are going to be using for our work. In this Scottish study, the authors tested several analytical methods, perhaps not quite the G methods I've introduced today, but certainly related methods, and found that some of them were able to provide reliable results, whereas others weren't. And the authors concluded that these kinds of analyses obviously do need to be interpreted with caution. So we've seen that analysing observational data is difficult and requires special methods and good data quality. Some people have had success with this, others have had not so much success. I should also say though that when I've distilled these results down to fact or fiction, that is done quite tongue-in-cheek. Nothing is ever so cut and dry. And indeed, I think the authors of all the studies I've referred to have acknowledged in their papers that residual confounding may remain in their analyses. But given all of this, can we do these kinds of analyses reliably using English Cancer Registry data? To help with that question, I think it is worth having a quick look at what these data sets contain. So the NCRAS data include 3 data sets that I think are of particular interest to us. The Cancer Registry data set, the Systemic Anti-Cancer Therapy data set, and the Hospital Episode Statistics data sets. There are other data sets available from NCRAS, and the variables that I include in the slides coming up are not exhaustive, but it gives you an idea of what's available. So the Cancer Registry dataset includes variables on things like age, sex, diagnosis date, tumour site, grade, size, histology, stage of disease. It also includes Charlson Comorbidity Index, geographical information, including things like social deprivation, and the date of death if the patient has not survived. The Systemic Anti-Cancer Therapy dataset bills itself as the world's first comprehensive database allowing us to understand treatment patterns and outcomes on a national scale. So I suppose quite grand claims, and it includes data on things like height and weight, also performance status, ECOG performance status, and an indicator that records whether or not the treatment decision was affected by comorbidities, which could be quite useful. and of course a lot of details on the treatment received. And finally, the hospital episode statistics, information on all the secondary care a patient has had, including inpatient care, outpatient care, and accident and emergency episodes. So that's a very quick overview of the data available from NCRAS, but on the face of it, it seems like a reasonably good breadth of data on potentially prognostic variables. But the question remains, is this enough to satisfy the assumptions of the causal inference G methods that we're going to want to use? Do we have enough data on prognostic factors measured over time to satisfy the key assumption with these methods, which is that there is no unmeasured confounding? We need information on all the prognostic variables that influence the treatment decision and the outcome. And also, looking at data dictionaries is one thing, but another matter entirely really is whether the recorded data is of good quality and accurate. So, I'm very well aware that I haven't actually given you an answer to the question posed in the title of this talk, which might be quite a disappointment for some people, and sorry about that. But that's because we haven't done the analysis yet. The plan is to take a similar approach to that being used in that RCT duplicate project, but our analyses will all be in cancer and we'll use English registry data. So we're going to emulate 9 existing RCTs and conduct appropriate analyses that attempt to control for confounding and compare the results that we get to those seen in those existing RCTs. These are the 9 case studies that we'll do between me, Salima and Amy in their PhDs. And we'll be covering studies in pancreatic, lung, breast and prostate cancer and renal cell carcinoma. It's quite a range. Okay, so I'm not going to talk for much longer. So just to finish off with some discussion points, and I'm happy to answer any questions or see what the discussion's like in the chat. So I think it's fair to say that we should try to make use of the data that we collect, given we collect a lot of data. And sometimes RCTs don't answer the questions that we would like them to. So we want to see if we can use our registry data to reliably estimate the comparative effectiveness of treatments given in clinical practice. I think that could be helpful for healthcare decision making. It could be helpful for clinicians and hopefully to the benefit of patients. But the key question is whether the data we have is good enough to allow us to do these analyses reliably. So this is what we'll be investigating over the next couple of years. If we find that the data are good enough, then we may have the confidence to start using these data to start exploring more questions beyond those addressed already in RCTs. If we find that the data aren't good enough, then we hope to identify what the limitations of the data are, whether more or better data could be collected in future so that we can do such analyses in the future. So fundamentally, I don't yet know, I'm afraid, whether we can use our cancer registry data to reliably estimate the comparative effectiveness of treatments given in the NHS. But do watch this space. Hopefully we'll have some answers on this in the not too distant future. So these are the references for the papers I've talked about today. And finally, thanks very much for listening. So I'll stop there and hand back over to Claire, or we can have a look at the chat.
Okay, thanks for that, Nick. So any questions? Like I say, you can type them into the chat. Yes, already. Okay, and yes, so you can type them into the chat, or if you do want to switch your mic on and ask a question, that's okay. The first question is from Stella O'Brien, who asks, does Nick have any informed expectations of what the difficulties with the cleanliness and relevance of RW data might be to make it useful for decision making, please? So the difficulties with cleanliness and relevance of real world data. Yeah,
so I mean, I think a lot will become clear when we actually start looking at the data, but speaking to oncologists already, who are really helping with this research, because when you're designing these analyses, you need to know what these prognostic variables are. So it's crucial that you have clinical input to that. But speaking to the oncologists so far about the data that they're asked to input on these registry systems, I do have concern about some of the variables. In particular, the performance status variable, ECOG, is measured, which theoretically should be really useful. But from what I understand, it may not always be recorded accurately, in particular because some treatments are only available to people who have a specific ECOG, performance status score. And so sometimes perhaps the ECOG performance status score that is recorded is the one that allows the person to get the treatment and may not be actually the ECOG score that the patient really has. So that kind of thing would be a real concern.
Okay, the next question, oh goodness, there's loads. We're going to be here for a while. The next question is, how valid is the assumption that the RC data gives us the right answer as fact, not fiction?
Yeah, that's a good point as well. And I mean, and sometimes confidence intervals from those studies are quite wide as well. So, I mentioned that RCT duplicate, the number of times the observational data analysis gave you a treatment effect that was within the 95% confidence intervals. In the duplicate project, they are also looking at a range of other kind of metrics for comparability to see if the method seems to have worked or not, and that's what we'll have to do as well. It won't just be looking at are the results within the 95% confidence interval. But yeah, sometimes you do get RCTs that give maybe unusual results and have wide confidence intervals.
Okay, the next question says, this is from Alistair, who says, are you going to compare multimorbidities between the data set and the RCT? The challenge with some RCTs is they exclude many patients who will receive treatment in real life.
Yeah, absolutely. And that's why we would quite like to be able to use these data sets to look at what's the effectiveness of these treatments in clinical practice in patients who aren't allowed into RCTs. But for the emulation of the RCTs, we will, as closely as possible, try to use the eligibility criteria used in the RCT so that we are doing an analysis where we're trying to compare like with respect to populations. But if we show that we are able to do that, then we would obviously like to go on and look at, okay, so what's the effectiveness in a wider population, people who do have more comorbidities.
Okay, the next question is from Barris, who says, DAGs seem to be a very important step before we actually do any statistical analysis. Are there best practices around building and validating them?
Yeah, and there's lots of people who know a lot more about DAGs than me. I mentioned the course that I teach on in Austria, and Uwe Siebert, who's on this call, spends the best part of 2 days talking about DAGs and how to use them. There's also plenty written in the literature about how to use them. I mean, there are pros and cons with DAGs. I like them. I think they are useful, but some people are not so keen. But yeah, have a look at the literature. There are papers about how you should use DAGs for this purpose.
Okay. Adam asks, can you comment as to how to decide when you might have identified and accounted for all the relevant variables to allow analysis? Donald Rumsfeld's unknown unknowns. Is Donald Rumsfeld's unknown unknowns a factor?
Yeah, I mean it is, and the issue is that there is not a perfect test for whether you've got no unmeasured confounding. We can't do some statistical test that will tell us you now have no unmeasured confounding. We don't know. That is where I think DAGs are very useful, because if you ask clinicians to write down all the factors that influence their decision making, that can be really helpful. One thing that I think is also important is that when you talk about the no unmeasured confounding assumption, some people immediately think that means we need data on everything. But that's not necessarily the case. So just a hypothetical example where this won't be factually true, but imagine you have a performance status variable and a tumour size variable, and you have information on performance status but not on tumour size. Unless tumour size has an independent effect on the treatment decision, outside of through the performance status variable, we don't actually need the tumour size. In our analysis, we can block that backdoor path just by controlling for performance status. So understanding the relationship between the different variables, where their effect is through another variable, is really important and allows us to see which variables we do really need to have. There is also ways of doing sensitivity analysis around, imagine we do have an unmeasured confounder, what is the maximum potential impact that could have on our results, given that it's an important unmeasured confounder. I think it's called the E-value. But there's, again, quite a lot written about that kind of analysis, which is probably important to think about.
Keith Abrams asked, should we be thinking of emulating RCTs using observational data, or rather using observational data to augment RCTs?
I mean, I would say we should be thinking about both, because emulating RCTs using observational data tells us about whether the observational data is sufficient to be able to do those analyses reliably, and then we can move on and try to do some other analyses with them. But also, you know, as we are collecting so much data in registries and other observational data sources, whereas RCTs are kind of sometimes a little bit more restricted, then yeah, ways of kind of augmenting the RCTs with the observational data also very valuable. I think both things are valuable.
Okay, we've just probably got time for 2 more questions. Andrea asks, do you think the target of the causal inference method you presented today should be to validate the results of RCTs?
Well, I mean, that's where I was kind of saying it's an interim step, the way that I see it. You know, you try to test whether these methods give you results using the observational data that are similar to the RCTs. I suppose, I mean, actually, there's several ways of thinking about it. I kind of think of that as an interim step before we go on to use the observational data to answer other questions that RCTs haven't answered. I suppose what Andrea is saying is that if we're not certain about the results from an RCT, we could do the analysis on the observational data, and that might help us decide whether the RCT result is good, is the true effect or not. I think that's tricky because, you know, if we're using the emulation of RCTs to test whether we think the observational data are good enough, then we say, well, the observational data is giving a different result. Which one's a truth? You know, it's a little bit circular. I think it's tough. There probably is some scope to thinking about that. There definitely is, but I think it's a tricky one.
Okay, and then one last question from James Fotheringham. He asks, do you envisage needing to reanalyze the trial data to account for treatment switching and other aspects which de-estimation is also dealing with?
Yeah, I mean, that's another good question. You know, if things happen in the RCT that we don't think would happen in clinical practice, so say patients in one group switch onto a different treatment, which wouldn't happen in clinical practice, then the results from the RCT that are published might not actually be the results that we want to compare to. And so, I mean, it's very important when we're trying to emulate these RCTs to define what the treatment strategies are that we're comparing. That's a crucial part of it. And Miguel Hen and Jamie Robbins have got a really useful paper on emulating trials using something called a target trial framework. So anyone interested in this, I would highly recommend read that paper. But you need to define the treatment strategies. But yeah, as James kind of points out, sometimes the treatment strategy in the RCT might not be something that we see in clinical practice. And so we might actually want to try to reanalyze the RCT data to get to a treatment effect that we can compare to using the real world data. And then obviously you do need the patient level data from the trials to be able to do that.
Okay, I think that's probably everything we have time for in terms of questions. So thanks everyone for joining us today. It's been a really busy one, lots of attendees and lots of quite great questions, which is really, really nice to see. Andy has just mentioned in the chat, we didn't have the details earlier on to put it on the slide, but the next one of these talks is with Professor John Brazier. That will be on the 16th of March. The details aren't on the Eventbrite yet, but the link in the chat, the details will be there very soon. I think Andy's literally in the process of putting them on right now. But thanks for joining us today, everyone, and hopefully we'll see quite a few of you on the 16th of March.